Alrighty, good morning, everyone. How's everyone doing this morning? I have a very special guest on today. His name is Dr. Angelo Cardarelli, and he's from Italy. So say hello, doctor.
Hello, good morning, everyone. Thank you for your kind invitation.
Great, no problem. So Dr. Cardarelli graduated with Load in dentistry and dental prosthetic at the University of La Caia.
L'Aquila.
And
Don't worry. It's difficult words for you.
yeah, La Akia. Oh, there you go. La Akia in 2007, specializing in oral surgery at the Sapienza University of Rome in 2010. He is an adjunct professor and a tutor at the San Rafael University of Milan. He is a scientific advisor to the dental clinic at the Department of IRCCS San Rafael in Milan. He worked in Milan and in Cernia, where he practices implant prosthesis and oral surgery. Author of many publications, speaker of the National Congresses on Implantology and Oral Surgery, member of the San Rafael Implant Cultural Association, the SIMO, Società Italiana Maxillo Endont. You get what I'm talking about. And the member of the IAO, Italian Academy of Osteointegration. I would love to welcome him to everyone. Dr. Cardarelli, welcome. And everyone enjoy the webinar. Thank you.
Thank you very much, and good morning, everyone. I'm glad to spend some of my time with all of you today. Despite the critical situation about the coronavirus infection in Italy, in Europe, and around the world. So today I'm gonna share with you my topic about the atrophic jaw rehabilitation using a minimal invasive approach to reduce the invasivity and the morbidity for our patients. A new protocol, a new technique to treat particular type of patient with bone resorption to avoid, as you will see later, bone regeneration, to avoid the another surgery, to obtain in only one step, in only one surgery, a good prosthetic implant rehabilitation, as you will see later. I will show a short video about my academy in Italy, in my clinic. In fact, I do during the year many courses about oral surgery, about implantology, with the theoretical part, with hands-on training, and with also live surgery. Sorry. So, the topic of today, it will be on atrophic jaw rehabilitation using a tilted implants, using a reduced number of implants, a new minimal invasive approach, as you will see later during my lecture. Before we start, I'd like to introduce myself. I come from a small town in the south of Italy, Cernia, as you can see, where I work in my clinic with my brother and my father. As you can see, this is my clinic, and I have a dedicated room, as you can see in the right side, for the oral surgery and implantology, a dedicated operating room. And I have a first floor of my clinic dedicated for pediatric and orthodontic treatment, because I think it's very important to have a multidisciplinary approach in our technique. It's very, very important. And I spent some of my time in Milan as adjunct professor at San Raffaele University and oral surgeon in the San Raffaele Hospital in Milan. This is my team of work, and on the left I was with the ideator of the all-on-4 concept, most famous in the world, Professor Paul Malone. He introduced the new approach to rehabilitate the atrophic jaw, upper and lower jaw. And I'm glad to be one of the members of the International Extraction Academy of California. And I'm very happy for that. So now we can start. As you can see from this graph, in the latest years, the numbers of the dentulous people is increased. And in the next years, there will be about 30 million of the dentulous people in one or in both arches. So it's very important to know different technique to treat this patient. Is very, very important. After the tooth extraction, it's very important to know what's happened after tooth extraction. As you can see, in the first 6 months, we have a bone loss about 23%, especially in the vestibular side, as you will see later. In the next 2 years, we have another bone loss about 11%, and at the 3 years later, we have a bone loss about 40%. So it's very important to treat this patient to avoid the bone resorption, to treat the bone resorption, and to preserve the bone and the shape of the soft tissue, as you will see later. Is very, very important, because after tooth extraction, we have a change of the shape of the bone and the soft tissue, as you can see from the most famous classification about bone resorption, the classification of Cable and Owen, as you can see in the left side and in the right side. We have 6 classes in the mandible, from the first class, where we have a sufficient bone, where we have a dental elements, where we have a good blood supply, and we have a full bone around the dental elements. After tooth extraction, we have a bone resorption until to the last class, where we haven't a sufficient bone. So in this case, it's impossible to place the implant to treat the patient without bone regeneration or alternative techniques. In the maxilla, we have the same bone resorption. As you can see, we have 5 classes, from the first class to the last class, where we haven't a sufficient bone. So the same bone resorption in the maxilla and in the mandible, but with different direction and with different speed, as you will see later. Is very, very important, because during the persistence of the dental elements in the bone, we have a sufficient bone supply. So we have a management of a good management of soft tissue, a good vascularization of the bone, as you can see from the histological result. But after the extraction, we haven't a good blood supply. And after, we will have a bone resorption. And it's very important in the oral surgery, and especially in this type of treatment, to know the anatomical structure. As you can see from the cadaver dissection, on the left, we have the vascularization and the innervation of the mandible and of the lower jaw. As you can see on the right, also in the cadaver dissection, it's possible to see the anatomical structure of the maxilla, the emergence of the palatine nerve, the emergence of the infraorbitary nerve, the shape of the bone after the extraction. Is very important to know the anatomy, especially during the skeletization of the bone, to obtain a good surgical view, as you can see later. Have a look at this case, simple case, after the extraction of the dental elements in the aesthetic zone. As you can see, after the extraction, we have a change of the bone and a change of the soft tissue. As you can see, we have a reduction of the thickness and the height of the bone, and also the thickness of the soft tissue, and is very important, the management of the soft tissue, especially in the aesthetic zone, but also in the rehabilitation of the atrophic jaws is very important, the management of the soft tissue. Another cadaver dissection, as you can see on the left, we haven't in the posterior side of the mandible a sufficient height, a sufficient thickness, as you can see. And in the right side, it's possible to see the superficial emergence of the mental nerve. So it's very important to know this clinical situation, especially in the patient with a severe atrophy, because it's very important to do a good flaps design to avoid the emergence of the mental nerve. It's very, very important to know the anatomy and to know the alteration of the anatomy after the bone resorption. It's very important. We have many studies about the bone resorption. As you can see, after 1 month, after the extraction of the single molars and the premolars, after 1 year, we have a 50% of bone loss. And the average diameter of a bone before the extraction is 12 millimeters, as you can see. After 1 year, it will be 5.9 millimeters. So we have a bone resorption with a different direction, horizontal direction, vertical direction, and with different speed. Is very important. Another publication, another study about the bone resorption, 120 mandible of a cadaver with extraction after 3 months. As you can see, we have a change of the shape of the bone from the left side to the right side, change of the bone. And the bone loss is more important when we have more extraction, as you can see, because we have a change of the shape of the bone. Is very important, this concept. Also, we have a change of the shape of soft tissue. As you can see in this case, for example, in the mandible, the patient has a dentulous mandible. So we have a change of the soft tissue. We have a reduction of the thickness and the height of the alveolar crest, an increment of the intermaxillary relationship. And it's very important to know the alteration of the vertical dimension, because in this type of surgery is very important for the final prosthetic result to have a good artificial gingiva to improve the vertical dimension, to obtain a good relationship between the upper and the low jaws. It's very, very important. We will have, for the bone resorption in the mandible, a third skeletal class. We have a reduction of the keratinized tissue and the quality of the bone. And it's very important, the management of this alteration, those alterations, sorry. So in the maxilla and in the mandible, we have a different direction of the bone resorption. As you can see, in the maxilla, we have the quality of the bone is lower respect to the mandible, especially in the posterior side. In the posterior side, we have a cancellous bone. The quality is very lower, and we have a maxillary sinus and the hyperpneumatization of the maxillary sinus to reduce the bone after the tooth extraction. Is very, very important, the hyperpneumatization of the maxillary sinus after the extraction. We have in the maxilla a centripetal resorption with a reduction of height and thickness, especially in the posterior side, and an increment of the maxillary relationship. In the mandible, we have another direction of the bone resorption. We have a centrifugal resorption, as you can see. We will have a third skeletal class, as you can see. And in the mandible, we have a lower quality of the bone in the posterior side. Best quality of the bone is in the anterior side. And following this approach, it's possible to place the implant in the anterior side of the mandible, avoiding the posterior side where the quality is lower and avoiding to the emergence of the mental nerve. So in the mandible, frequently we have a reduction of height and thickness in the posterior side. In the anterior side, we have a good quality of the bone, a good height, and frequently a good thickness. Also, in the mandible, we have an increment of intermaxillary relationship, as is very important for the final prosthetic rehabilitation. For example, have a look at this simple case. After the extraction of a second upper molar, after 3 years, we have a vertical and horizontal bone loss with different direction and with different speed, as you can see. So after 3 years, as you can see in the right side, it's not possible to place the implant without bone regeneration. In this case, it's necessary to do before bone regeneration, like crestal sinus approach, like lateral approach, and after to place the implant. So the maxillary sinus lift for the maxilla is a good technique, is a predictable technique, as you can see from my publication. For example, the patient in this case hasn't a good sufficient thickness of the bone in the posterior side of the maxilla, as you can see from TC scan. So in this case, as you can see, I do maxillary sinus lift, and at the same time, I place 2 implants with good primary stability, because in my practice, in my experience, when it's possible, I place always the implants at the same time to the maxillary sinus lift to reduce the bone resorption during the healing. The X-ray post-op below on the right side, and in the right side, the final prosthetic rehabilitation and the TC scan to shows the good healing of the bone after the maxillary sinus lift. So it's a good technique, a predictable technique. Also in this case, for example, the same approach, I do maxillary sinus lift with the lateral window. I place at the same time 2 implants with the good primary stability, and I fill the cavity with a mix with autolog and heterolog bone. And I do the suture. But this technique is more invasive for the patient. So it's possible to introduce a new approach to reduce the invasivity, to reduce the morbidity, especially in patients with particular systemic disease, like alteration of the coagulation, diabetes, high blood pressure, for example. And have a look at this old case. In this case, the patient has 12 implants in the maxilla, as you can see, but it's possible to see also the severe in the right side, in the upper right side, severe perimplantitis, because as you can see, in this case, we have more titanium, more implants, and less bone. So it's not possible to obtain a long-term survival, a good blood supply for our implants. So in this case, especially when the implants are very close, it's not possible to have a good blood supply, as you can see. So it's better to have more bone, more vascularization, more blood supply, and less titanium. This is new approach to obtain the same result with the minimal invasive approach. As you can see, this is the opposite approach, only for implants, for example, for the full maxilla rehabilitation. So in this case, we have more bone, more vascularization, and less titanium. This is new concept, this is new approach to obtain the same result, reducing the invasivity for our patient. But it's very important, as you will see later during the webinar, to follow always the protocol. So with this approach, it's possible to reduce the operating time, to reduce the economical and the biological cost for our patient, to have a simple technique, to have a standard protocol, but it's very important to follow always the right protocol. This is our goal. According and considering the age of the patient, the general state of health of the patient, the residual state, the state of the residual dental elements, the intermaxillary relationship and the shape of the residual crestal bone and the soft tissue is very important to obtain a good long-term survival of our implants. So with the new minimal invasive approach, it's possible to obtain less invasivity, faster treatment, to reduce the cost, to obtain the same outcomes, the same results is very, very important. It's possible to have different clinical situation in the maxilla. For example, when we have a sufficient bone in the posterior area, it's possible to place the implants according to the traditional technique, axial implant, as you can see. If we haven't a sufficient bone in the posterior area of the maxilla, it's possible to use alternative technique, maxillary sinus with the lateral crystal approach, bone regeneration, but now I will introduce new approach with tilted implant to increase the surface contact between the implant and the bone, because especially in the maxilla, I will use always very long distal implants to obtain a good high primary stability. I reduce with the tilted implants the cantilever, and almost always I do the immediate loading. And when it's possible, I prefer always to do immediate loading, because the immediate loading is the best way to improve the ost integration around our implants. Another alternative techniques to avoid the maxillary sinus, for example, tilted implants, pterigo implants, transsinus implants. It's possible to pass in the sinus with the implants to obtain a good primary stability, to enter in the sinus until to zygoma rehabilitation. But this is not our topic today. In all type of surgery, it's very important to have a good ergonomical approach and to have a good instruments for this, for each type of surgery. Is very, very important. As you can see, it's very important to have a good ergonomical approach, to have a good line, to obtain a good surgical view, to have two dental assistants, one for the suction and for the retraction of the flap, for the flaps, and another dental assistant to pass the instruments during the surgery. Is very, very important. And I do always this surgery with conscious sedation, because with the conscious sedation, it's possible to reduce the anxiety of our patient. It's possible to reduce the bleeding, to reduce the blood pressure during the surgery, to obtain a good surgical view. So I do always this surgery with the conscious sedation. As you can see in the right with the small video about the procedure of conscious sedation, a simple procedure, as you can see. And on the left, the clinical situation in the patient with particular systemic disease, like alteration of the coagulation. This is on the left, the clinical situation of the patient after 1 week after the surgery of the upper jaw. But this clinical situation is a normal situation in this type of patient with a particular systemic disease. So it's very important before our surgery to have all information, all details about the general state of health of our patient, as you can see. And this is the simple procedure to do the conscious sedation. And now it's possible to inject the drugs to reduce the anxiety of our patient. This is another important details to improve a good final result of our surgery. This is the drugs to reduce the anxiety of our patient. And in my practice, depending from the general state of the patient, I do always 4 milligrams of cortisone before the surgery and 4 milligrams immediately after our surgery to reduce the edema, to reduce the swelling, and to reduce the pain after the surgery. Is very, very important. We have different type of tools to check the heart activity, to check the saturation of the blood, to check the pressure, the blood pressure, like this. So, as you can see, when we have a sufficient bone in the posterior side of the maxilla, it's possible to place with easy approach our implant. This is a simple case. I place 4 implants, 2 implants in the right side and 2 implants in the other side, the left side, following always the final prosthetic plan, the final prosthetic result. Because in my practice, I never use, according to my knowledge, according to my experience, and according to my skills, I never use the surgical guide, but I always use the prosthetic guide. I place the implant according to the final prosthetic result. For example, in implant prosthetic rehabilitation, I think is necessary to always use the screw at the crown, as you can see. So if I place the implant with the wrong approach, it's not possible to obtain a screw at the crown. So it's very important to place the implant in the bone, but following always the final prosthetic rehabilitation is very, very important to obtain also a good healing, a good management of soft tissue. For example, in this simple case, I always use the provisional prosthetic rehabilitation to manage, to obtain a good shape of the soft tissue, as you can see. And this is the final prosthetic rehabilitation with good healing of the soft tissue and good aesthetic result. As you can see on the left, the X-ray post-op, we have a sufficient bone in the posterior side. So I place my implants with the traditional approach, axial implant, because we have a sufficient bone. So it's not necessary to tilt the implant in this case or to do the maxillary sinus lift. And on the right, the final prosthetic result. Good management of our patient. Another case, for example, also in this case, we have a sufficient bone in the maxilla, as you can see, but the patient has a severe periodontal disease, as you can see, in the maxilla and in the mandible, and on the right side, the extraoral situation. So in this case, it's not possible to preserve the residual dental elements, so I removed all residual dental elements, and at the same time, I placed 6 axial implant, as you can see, because we have a sufficient bone also in the posterior area, and also in this case, I do immediate loading, as you can see on the right side. This is the provisional prosthetic rehabilitation with a perfect balance of the occlusal loading. As you can see, we have a good parallelism between the implant, as you can see. And this is the situation after 6 months with a good healing and a good aesthetic result of soft tissue and above the final prosthetic result. Also in this case, I used the fake gingiva to increase the vertical dimension to obtain a good shape of the dental elements and to obtain a good intermaxillary relationship. Is very, very important. The details about the final prosthetic rehabilitation, Toronto screwed made in ceramic, as you can see, the X-ray post-op, 6 axial implant, and the above the final prosthetic rehabilitation. Screwed Toronto made in ceramica on 6 axial implant, as you can see, because we have assumption bone. The same approach in the mandible. When we have a sufficient bone and sufficient thickness, as you can see, for example, I placed the 4 axial implant for full mandible rehabilitation, as you can see. In the posterior area, we have a sufficient bone, a sufficient height, sufficient thickness of the bone. So I placed 4 implants, but as you can see, it's very important to follow always the parallelism between the implants to obtain a good management of the provisional prosthetic rehabilitation. And as you will see later, during the implant site preparation, I check always the direction and the emergence of my implants. This is our goal. And it's very important, as you can see on the left side, to have a good surgical view. The bone skelettalization, the flaps design is very important to obtain a good view during our surgery. Is very, very important, as you will see later. For example, in this case, as you can see from the left side and the CBCT reconstruction, the TC scan, we have a sufficient height also in the posterior area of the maxilla, but we haven't a reduction of the thickness, as you can see. But using a correct protocol, it's possible to treat this patient without bone regeneration with only one step. As you can see, I do the palatal surgery, the palatal flap approach, as you can see on the right picture above. And with the palatal approach flap, it's possible to place the implant with the palatal side, with the palatal approach, to preserve the vestibular bone, as you can see, and to increase at the same time the keratinized tissue around our implant. In this case, I placed 6 axial implant without bone regeneration, using only the palatal approach to preserve the bundle bone with the palatal flap approach. And as you will see later in the next cases, I used always the suture to hold the flap to obtain a good surgical view to place the implant with the correct prosthetic approach. Is very, very important. But it's very important to see the result after 6 months. Also, in this case, I do immediate loading with the 6 axial implant, with the 6 provisional abutment. On the right, the provisional prosthetic rehabilitation without cantilever, and above the final result after few hours after the surgery, as you can see. But it's very important to see the outcomes after 6 months. As you can see, we have amazing healing of the soft tissue around our implants. With the palatal approach, it's possible to place 6 implants and to increase the keratinized tissue around our implant. Is very important to avoid the future mucositis and the future perimplantitis. Is very important the management of the soft tissue. So in this case, with only one step, with only one surgery, it's possible to place the implant to increase the soft tissue and to do immediate loading. This is our goal. Minimal invasive approach to obtain the same result, the good aesthetic and the functional provisional and after final rehabilitation. Is very important. But when we haven't a sufficient bone in the posterior area of the maxilla, it's possible to use a new approach, tilted implant, to avoid the maxillary sinus, to reduce the invasivity, to reduce the morbidity, obtaining the same result. The concept about tilted implant was introduced by Kreckmanov 20 years ago. According to this protocol, it's possible to reduce the number of implants in the mandible and in the maxilla. In the mandible, I will place the implant in the anterior side between the mental nerves, avoiding the posterior side of the mandible, because frequently we haven't a sufficient height, sufficient thickness, and the quality is lower than the anterior side. So tilting the posterior implants in the mandible, it's possible to use the long implants to increase the surface contact between the implants and the bone, to avoid the emergence of the mental nerve, and to reduce the cantilever. This is our goal. The same approach in the maxilla. It's possible to use only 4 or 6 implants, 2 distal implants with the tilt approach to avoid the sinus, to use a very long implant to obtain a good primary stability, to do immediate loading, and to increase the surface contact between the implants and the bone, avoiding the posterior side of the maxilla when the quality is lower and when frequently we have an hyperperimatization of the maxillary sinus, as you will see better later. We have different solutions about the alternatives of the maxillary sinus: tilted implants, pterygoid implants, short implants, and all on 4 concept. 4 implants for full arch rehabilitation in the maxilla and in the mandible. In the maxilla, using 2 axial implant and 2 tilted implant to avoid the maxillary sinus, and 2 by anchoring on the nasal basal bone, because in this site we have high quality of the bone to do immediate loading to obtain a good primary stability. The same approach in the mandible with 2 distal tilted implant to avoiding the emergence of the metal nerve and to reduce the cantilever. This is the correct approach. As you can see in this case, for example, in this case, as you can see from the left side, the patient has a failed implant. So using this approach, it's possible to remove the failed implant with the severe perimplantitis and at the same time to place 2 implants, 1 axial implant and 1 tilted implant, as you can see with the yellow line, following always the anterior wall of the sinus. Is very important using a very long implant to obtain a good primary stability to do immediate loading, and it's very important to place before the tilted implants and after the axial implant, because if I place it before the axial implant, it's not possible to change the position of the distal implants. So with the correct approach, it's necessary to place before the distal implant, as you can see. And I do also in this case provisional rehabilitation, immediate provisional rehabilitation without occlusal loading for the first 4 months after the surgery is very, very important. It's different in case of the full arch rehabilitation, as you will see later. In this case, I do only aesthetic immediate restoration without occlusal loading, without occlusal contact. I use the extreme abutment to obtain a good emergence to reduce the angulation of my implants, and the X-ray post-op, 1 axial implant and 1 distal implant to avoid the maxillary sinus. 1 step, 1 surgery and immediate loading. And the situation after 6 months, with the final prosthetic result, with the screwed bridge, as you can see, and the X-ray to shows a good osseointegration of our implant. Minimal invasive approach to reduce the operative time at the same time. Have a look at this case, another case of the failed implants, as you can see from this surgical video. Sorry. Okay. This is the initial situation. As you can see in the right side, we have a crazy placement implant. This is the X-ray pre-op 3 implant with the severe perimplantitis, the intraoral situation with wrong placement, wrong direction, wrong emergence of our implant, as you can see. So it's not possible to preserve those implants. So in this case, I removed the abutment and I decided to remove the implant. The occlusal view using a particular tools to remove the implant to preserving the residual bone. As you can see, I remove all implants, but it's very important to preserve the bone to place at the same time the other implants. As you can see, and the last implant, as you can see, the wrong placement and the wrong emergence of the implant is completely wrong direction. The implants after the extraction, the occlusal view, and now is very important to choose the correct flaps design with the palatal approach. Is very, very important with the 1 vertical mesial incision. With the palatal approach, it's possible to obtain a good surgical view and to increase the soft tissue and the keratinized tissue around the future implants. The situation after the extraction of the residual failed implants, the occlusal view, and now it's possible to place the implant. Before to start with the distal implants, I use the fist drills and I check always the correct direction of the implants. And if is okay the direction, it's possible to go on. I check the direction, as you can see, following always with the next drills the anterior wall of the sinus. And it's need to under-prepare the implant site to obtain high primary stability to do immediate loading. Is very, very important, especially in the maxilla where the quality of the bone is lower. So it's very important to do under-prepare the site. And now it's possible to place the implant, a very long implant, 3.75 of diameter and 16 of length to obtain a high primary stability. In this case, I continue with the manual mounter, and the final primary stability is over 50 Newton. Now it's possible to prepare the anterior side. I changed the direction of the fist implants and I check always the correct direction and I continue to prepare the implant site. And now it's possible with the underside preparation to place the implant with high primary stability, 3.75 of diameter and 11.5 of length. High primary stability, more than 50 Newton. I placed the multi-unit abutment, the occlusal view, and I covered the bone fenestration dehiscence with the resorbable membrane. I used the healing cap for the suture, the X-ray post-op, and also in this case, I do immediate loading. Sorry, immediate provisional rehabilitation without occlusal loading. As you can see, immediate prosthetic rehabilitation without immediate occlusion loading is very, very important. It's important to follow the protocol to obtain a good healing of the soft tissue, as you can see in the mandible rehabilitation, to improve the long-term survival of our implant is very, very important. And this is the schematization for this approach. It's possible to use also the surgical guide. In my experience, actually, I never used the surgical guide, but depending from the knowledge, the experience, and the skill. This is the surgical guide to place the tilted dentaxial implant. Tilting the implant between 30 degrees until to 45 degrees. Depends from the anatomy, from the bone resorption. So it's possible to tilt the implant between 30 degrees until to 45 degrees, depending from the bone resorption and from the anatomy. As you can see from this clinical case, I placed the surgical guide and the implant size preparation with 2 axial implant and 2 tilted implants. It's very important to have a good parallelism between the implants, to have a good management of the provisional prosthetic procedure and the provisional prosthetic result. The surgical phases, on the left, the implant site preparation, on the right, the use of the multi-unit abutment, and the situation after 4 months during the final prosthetic rehabilitation. As you can see above in the middle picture, we have a sufficient thickness, a sufficient keratinized tissue around our implants. It's very, very important to obtain a good long-term survival. Using this approach, it's possible to treat also an extreme case, an extreme atrophy, like this case. The patient hasn't a sufficient bone in the height and in the thickness in the mandible. As you can see, we have a superficial emergence of the mental nerve. So in this case, in the mandible, we have a little bit bone in the anterior side of the mandible. And using this approach, it's possible to use only basal bone to treat this patient. On the right, the intraoral clinical situation and the surgical phases. Also in this case, I placed 4 implants, 2 axial implants, 2 straight implants, and 2 distal implants. And I do also in this case immediate loading. But as you can see, it's very important the flaps design. In this case, I don't use the distal vertical incision like trapezoidal flap, but I use only one medial incision to avoid the emergence of the mental nerve, because in this case, we have an extreme bone resorption and we have a superficial emergence of the mental nerve. So I do only one medial incision without 2 vertical distal incision. On the right, the prosthetic procedure, I placed the 4 provisional abutment, as you can see, and this is the provisional rehabilitation. Also in this case, as you can see, I used a fake gingiva. Is necessary in this tape, is always necessary in this type of rehabilitation, because with the artificial gingiva, it's possible to increase and to obtain a good vertical dimension and a good relationship between the mandible and the maxilla. So it's very important. And on the left, the situation after a few hours and the X-ray post-op. 2 distal implant avoiding the emergence of the mental nerve with 3.8 of diameter and 13 of length, and 2 anterior implants, 3.5 of diameter and 11 of length. And the situation after 4 months, as you can see on the left, a good osseointegration of our implants, and on the right, the final prosthetic result. This is orthopedic rehabilitation because it is necessary to have a fake gingiva to increase the vertical dimension in this extreme case of bone resorption. Using this approach, it's possible to treat, for example, at the same time, both arches. As you can see in this case, on the left X-ray, we have the initial situation. The patient has a severe periodontal disease, as you can see, and we haven't a sufficient vertical dimension. So it's necessary to make the provisional rehabilitation to increase the vertical dimension. And at the same time, I removed all residual dental elements with the high mobility, and I placed 4 implants according to the protocol in the mandible and 4 implants in the maxilla. And also in this case, I do immediate loading, as you can see on the right. Only 4 implants for arch to obtain immediate loading at the same time. Also in this case, the surgery has been done in conscious sedation. It's very, very important. So with the one surgery, one step, at the same time, it's possible to treat both arches and to do immediate loading with minimal invasive approach. But it's very important, to follow the protocol. This is not right protocol, as you can see. In this case, the colleague placed the implants with the casual, with the crazy approach, as you can see. He removed all dental elements in the maxilla and in the mandible, and he placed with the casual approach 4 implants in the mandible and 6 implants in the maxilla. But this is wrong approach. It's not possible to rehabilitate this patient with the right prosthetic approach because the colleague don't follow the protocol. Another wrong approach, for example, this is crazy approach. In the mandible, the colleague placed 4 short implants, but as you can see from the X-ray, we have a sufficient bone also in the posterior side of the mandible. So if we have a sufficient bone, I place 6 or 8 implants according to the traditional protocol without tilted implant. I use the tilted implants and this protocol always in particular type of patient and always when we haven't a sufficient bone. And on the right, the crazy prosthetic rehabilitation. So it's very, very important to follow the protocol. And this is the right protocol, as you can see. in the mandible, 2 straight implants and 2 distal implants. And it's very important to check always, as you can see, the emergence of the mental nerve. And I always use the pencil to mark on the bone the emergence of the mental nerve, to have a good surgical view and to say and to avoid the emergence and the injury of the mental nerve. And it's very important that the emergence of the distal implants should be on the top of the emergence of the mental nerve. It's very important to reduce the cantilever and to avoid the emergence of the mental nerve, because if I place the implants in the anterior side respect to the mental nerve, it's not possible to reduce the cantilever. So in this case, it's possible to place the implant with axial approach. It's not necessary to tilt the implant, but if if I want to follow the protocol, it's necessary that the emergence of the distal implant should be on the top of the emergence of the mental nerve. And on the right, the prosthetic procedure, I placed the multi-unit abutment and a few hours later, the immediate loading. In this rehabilitation, I do immediate loading only in the anterior side, between canine to canine, without immediate loading in the posterior side. And the provisional prosthetic rehabilitation has only 10 dental elements during the 4 months later in the mandible, 6 months later in the maxilla. Only 10 dental elements. After, I will have 12 dental elements in the final prosthetic rehabilitation. This is the right protocol, and I used in this approach always the multi-unit abutments according to the emergence of the implants. Sorry, I used the multi-unit abutment with 30 degrees in the posterior side, for example, and in the anterior side, depending from the emergence of the implants. In this case, I used the multi-unit abutments with 0 degree, as you can see. And it's very important to know the biomechanism about the axial implant and the tilted implants. In fact, the axial implants can work alone and can support the axial force, but don't support the lateral force. Instead, the tilted implants can't work alone because don't support the axial implants, and it can work only if linked with other implants. The tilted implants can't work alone, but only linked with other implants. This concept is very, very important. So in the mandible, this is the correct protocol. I place 2 distal implants before and after 2 straight implants, following the protocol. I check always, as you can see, the emergence of the mental nerve. And it's very important to have a good surgical view with a good flaps design in the vestibular and in the lingual side. And also in the mandible, I used the suture to hold the flap to have a good view of the lingual bone side. Is very, very important. And it's very important the emergence of the distal implant on the top of the emergence of the mental nerve, as you can see, to reduce the cantilever. Is very, very important, this concept. Another concept of this approach is the ostectomy. I do always the ostectomy in this approach to obtain a good plane of the bone, to place the implants at the same time. At the same level of the bone. Is very, very important in this prosthetic surgical rehabilitation. It's very important to obtain a good shape of the bone. As you can see in this case, this is not all-on-4 concept, this is not immediate loading approach, but only to show the correct approach about the ostectomy. As you can see on the left side, the initial situation, but it's not possible to place the implants before the ostectomy to obtain a good shape of the bone. As you can see in the right, after the ostectomy, I placed the implants at the same level is very, very important to obtain a good prosthetic rehabilitation. As you can see, after the ostectomy, as you can see, it's possible now, as you can see on the right side, to place the implants at the same level. So the ostectomy is another phase, very, very important in this surgical approach. And also in this case, I used only one medial incision to avoid the emergence of the mental nerve. I use only one medial incision to obtain a good surgical view. I do the ostectomy and I place my implants at the same level. It's very, very important. And this is the occlusal view to show the implant placement at the same level and after the ostectomy. So the ostectomy is very, very important before the implant placement is the strategic phase. To obtain a good final prosthetic result, because it's necessary to place the implant in the bone, but following always the final result, the final aesthetic and functional result. As you can see in different clinical situations, our goal is to achieve a good prosthetic result, a good aesthetic and functional result, as you can see. So it's very important, the placement following, as you can see from this image, the implant dentistry is a prosthetic discipline with a surgical component. Don't forget this concept. I place the implant in the bone, but following always the prosthetic approach is very, very important. So using this approach, using a reduced number of implants, it's possible, like, for example, 4 implants or 6 implants, to do a full maxillary or mandibular rehabilitation, avoiding the implant placement in the posterior area of the mandible and the maxilla, tilting the implant between 30 degrees until to 45 degrees, using a surgical guide, as you will see later, to reduce the cantilever, to obtain immediate loading, immediate static, and immediate function, avoiding the bone regeneration and reducing the invasivity for our patient. This is the schematization about the all-on-4 concept, for example, 2 distal implants, tilted implants in the maxilla by anchoring on the nasal basal bone, and 2 axial implants to reduce the occlusal force during the immediate loading, and the same approach in the mandible, 2 distal implants to avoid the emergence of the mental nerve and to avoiding the posterior sides of the mandible, and 2 axial implants. This is the correct protocol for this type of rehabilitation. And there are many studies about the atrophic rehabilitation. This is my publication about the atrophic mandible rehabilitation using a reduced number of implants. And I presented this work in last year in Dubai. So this is a predictable approach, predictable therapy. The same approach, the same concept in the maxilla, as you can see in this case. We have a sufficient height of the bone, but we have a reduction of thickness, as you can see. But using always the palatal flap approach, as you can see on the left, it's possible to prepare the implant site with the palatal approach, as you can see in the right picture, to preserve the bundle bone. And I use it always, in this case, the suture, to hold the flap, because in this approach, it's very important to use the anterior bone, avoiding the posterior side where we haven't a sufficient quality and a sufficient height and a sufficient thickness of the bone. So I place the implant in the anterior side, using only the residual basal bone. As you can see, I placed the implant site with the palatal approach, and as you can see on the left, I placed my implants with the palatal approach, and on the right, the occlusal view to show the implant placement with the palatal approach. And it's very important because in the palatal site, we have a good blood supply to improve the osseointegration in the next months later. And also with the palatal approach, it's possible to increase the keratinized tissue. This is our goal. Only one step, only one surgery to obtain good outcomes, good result. As you can see in this surgical video about maxillary rehabilitation, in this case, the patient hasn't a sufficient height in the posterior side of the maxilla after the teeth extraction, and we have a hyperpneumatization of the maxillary sinus. We have only residual dental elements with periodontal disease in the anterior side. So in this case, I decided to remove the residual dental elements and placed my implants using only the residual basal bone of the patient. So those are the surgical phases. I removed the residual dental elements with the minimal invasive approach also during the extraction to preserve the bundle bone is very, very important. So after the extraction now, it's possible to do the flaps design. Also in this case, I use trapezoidal flap with the palatal approach, as you can see, with the 2 vertical distal incision, according to the trapezoidal flap, to achieve a good surgical view during the surgery. This is the trapezoidal flap. As you can see now, it's possible to disconnect the flap, and this is the surgical view after the bone sclerotization. Also the residual cavity after I removed the inflammatory tissue. I used the suture to hold the flap. And as you can see, this is the occlusal view. It's possible to have a good surgical view. Now I do the ostectomy, and in this case I used the straightened piece with the drills to obtain a good shape of the bone before the implant placement. And it's possible to use also the clamps bone to obtain the bone chips, and I used the bone residual chips recovered to fill the residual cavity after the implant placement. Now, after the ostectomy, it's possible to place the implant. Before the tilted implants with the palatal approach, as you can see, I use the first drill and the second drill to prepare the implant site, as you can see, following always the anterior wall of the maxillary sinus, checking the X-ray, the OPT and the CBCT reconstruction. After the second drill, I check always the direction, and if is okay direction, it's possible to go on with other drills. As you can see, always it's need to under-prepare the implant site to increase the primary stability. As you can see, also in this case, I use a very long implants, about 3.75 of diameter and 16 of length, by anchoring of the nasal basal bone to obtain a good primary stability and to do medial loading. As you can see, I stop at about 30 Newton, I increase the Newton about 50 Newton, and I complete the implant placement with the manual device. As you can see, the same approach in the left side, first drill, second drill, following the anterior side, anterior wall of the maxillary sinus. I check always the direction, and if it's okay, it's possible to go on. And after, I place the same type of implant, 3.75 of diameter and 16 of length, with the correct direction, with the high primary stability. Now it's possible to prepare the anterior implant site with the palatal approach, as you can see, to preserve the bundle bone is very, very important. And after the first drill, is very important to check the parallelism and the emergence and the direction of the anterior axial implant, as you can see. Now it's possible to continue and to place the implant with high primary stability, also in this case, more than 50 Newton, as you can see. With the palatal approach, this is the palatal view. Now I placed the multi-unit abutments, 17 degrees in the anterior side and 30 degrees in the posterior side. The view, I do the suture, reabsorbable suture. It's very important, the management of the soft tissue around the extreme abutment. And this is the X-ray post-op. As you can see, 2-axial implant, 3.75 diameter and 13 of length, and 3.75 diameter and 16 of length to obtain a good primary stability in this site by anchoring on the nasal basal bone. This is our goal. So it's always necessary in the maxilla to use 2 very long distal implants. Because if I use in the distal side a short implant, it's not possible to obtain a good primary stability in this site where the quality of bone is very high. This is the correct approach. So it's possible to continue with the provisional prosthetic rehabilitation, the suture, the management of the soft tissue to increase the keratinized tissue around our implants, 4 implants abutment, as you can see, for the immediate loading, the provisional rehabilitation without minimal, I reduce the cantilever, the final situation a few hours later, as you can see, and the initial situation, and 6 hours later, this is the final aesthetic result. And the outcomes after 1 week later. So also in this case, I do immediate loading only in the anterior side without the loading in the posterior side on tilted implant. It's very, very important, this concept for the management of the immediate loading. Another case about in this case, the maxillary rehabilitation using a reduced number of implants. Is very, very important to follow always the protocol. As you can see, this is the initial situation. Also, in this case, the patient has a good healing of the residual dental elements. In fact, he has a severe periodontal disease in the maxilla and in the mandible. As you can see, the intraoral view, right side and the left side. As you can see, we haven't a sufficient vertical dimension in the posterior side. So it's very important to make a provisional prosthetic rehabilitation with a good vertical dimension to increase the intermaxillary relationship. The extraoral situation before our treatment is very important to have a good extraoral view, to choose the correct shape, the good shape of the dental elements according to the shape of the face of the patient. It's very important documentation about videos and about the photos, and the X-ray pre-op. As you can see, we have a severe atrophy in the posterior side. We have a hyperpneumatization of the maxillary sinus, so we have the bone only in the anterior side. So our goal, it should be to use only the residual anterior bone to place the implants and to do immediate loading, following always the right protocol. It's not possible to preserve the residual dental elements, as you can see. This is the CBCT reconstruction. We have also in the left side chronic sinusitis, as you can see, a little bit also in the right side, but we have a sufficient bone. Is very, very important to have a sufficient thickness of the bone to place our implants, and this is the thickness in the anterior side, and in the right side it's possible to see the bone resorption around the dental elements for the periodontal disease. So it's not possible to preserve the residual dental elements. So I will show a short video about this technique, but later I will show better each surgical phases. This is the initial clinical situation, as you can see, before our treatment. So I decided to remove all residual dental elements, the occlusal view, but we have, as you can see, a sufficient thickness of the soft tissue. Also, in this case, I used the trapezoidal flap with 2 vertical incision, distal incision with the palatal approach, the same approach, as you can see. I used the ostectomy, and after I placed my implants. Before distal implants, tilted distal implants, and after axial implant, following always the anterior wall of the maxillary sinus. And also in this case, I do medial loading because I obtain a high primary stability. And after I place anterior implant with palatal approach. The same approach in different clinical case. I placed the extreme abutment. I used the resorbable suture for provisional abutment, the final prosthetic rehabilitation with only 10 dental elements and with occlusal loading, as you can see, only in the anterior side, the X-ray post-op. But now I will show better each surgical phases and procedure. This is the situation after the teeth extraction. It's very important to have a good surgical view and to do a good skeletization, as you can see in the right side. It's very, very important. This is the occlusal view before and after. I use the suture to hold the flap, and this is the occlusal view. As you can see, we have a sufficient thickness of the bone, and I will place the implant with the palatal approach in the anterior side and in the distal side, as you will see. So after the ostectomy, following always the X-ray and the CBCT scan, it's possible to start to place the implant, as you can see. On the right, the X-ray pre-op, on the left, sorry, and below on the right, the implant site preparation. I use the fist drill to prepare the implant site with the palatal approach. And after the fist or second drill, I always check, as you can see below, the emergence and the direction of the implants. If it's okay, it's possible to go on, as you can see. So I use the next drills to prepare the implant site, as you can see, following always the anterior side with the under-prepared site. And now it's possible to place the implant. 4.0 diameter and 15 of length. Also in this case, very long implants to obtain high primary stability in the nasal basal bone site. It's very important. 30 Newton, I increase the torque about 50 Newton and I continue to place the implant. This is the situation after implant placement. As you can see in the left side, 4 implants with the palatal approach, as you can see. And in this case, I used the bone chips recovered from the ostectomy to fill the residual cavity around the implants and the vestibular bone, especially in the anterior side, where we have a gap between the vestibular site of implant and the bone. I filled the cavity with bone chips. I used the multi-unit abutment, 30 degree in the posterior side and 17 degree in the anteriors, in the anterior side. Yes, I used the 4 following the protocol for provisional abutment, as you can see. The correct emergence, the correct parallels of our implant is very, very important for the final provisional prosthetic rehabilitation. I used the resorbable suture, and on the right, the final provisional prosthetic rehabilitation with the medial loading only in the anterior side, without fist molars, and the X-ray post-op. 2 distal implant, 15 of length, and 2 anterior implants, also anterior straight implants, 4.0 diameter and 15 of length. So using this protocol, it's possible to use a very long implants to avoid the maxillary sinus and to obtain a good primary stability, avoiding bone regeneration. The summary about the surgical phases before the extraction, bone skeletalization, implant and prosthetic phases, and the final result few hours later. Always the same protocol, the standard protocol in different clinical case. Our goal is to follow the protocol. To obtain these outcomes, those outcomes after 4 months, good healing of the soft tissue around our implants, as you can see, and as you can see, it's possible to see the good shape of the soft tissue because the implants are at the same level after ostectomy. It's very, very important. So now it's possible to do the final prosthetic rehabilitation. In this case, I used the intraoral scan with the scan body, and I linked the scan body to obtain a good image of the scan and the 3D reconstruction on the left after intraoral scan, digital scan, and on the right, the final Toronto made in composite with the teeth made in zirconia, and is very important the shape of the fake gingiva to avoid that the food goes in the cavity between the fake gingiva and the tissue of the patient. It's very important to have a good shape of the fake gingiva to avoid the mucositis and the future perimplantitis. Some details about the screwed Toronto. In this case, we have on the right side the cantilever about 2 dental elements, and on the left 1 dental element, because in this case we have an extreme atrophy, especially in the right side of the maxilla. The occlusal view of the final restoration and the clinical procedure during the final prosthetic time, as you can see, only 4 implants for full maxillary rehabilitation with a good aesthetic result and a good function with the 12 dental elements, as you can see, with the good aesthetic of the fake gingiva. And it's very important to have a good shape of the artificial gingiva to avoid the mucositis and to obtain a good maintenance by our patient. And the final aesthetic result, as you can see, the intraoral situation, final situation, right side and the left side, as you can see, the frontal view and the occlusal view. The extraoral smile is very, very important to have a view of the extraoral smile. Also, in this case, we have a good aesthetic result according to the shape of the face of the patient and the situation before and after our rehabilitation. In the future, I will treat also the mandible with immediate loading using 6 implants, because in the mandible we have a sufficient bone in the posterior area, so I will place 6 axial implants. And I used a particular test, electromyography test, to check the muscle force between right and the left side. And after this test, as you can see, we have a good balance between the right and the left side. It's very important after the rehabilitation to use this test to check a good occlusion after final prosthetic rehabilitation. And this is the X-ray after the final restoration with a good healing of the bone and a good osteo integration. And there are many publications. This is my publication about the alternative to maxillary sinus lift using tilted implant. And if you want, you can find in this publication more details about this technique. Another, my publication about the minimal invasive approach in the treatment of the mandible and the atrophic maxilla using always a reduced number of implants. So I think actually, according to many publications, according to many cases, the using of tilted implant is a valid and predictable therapy to obtain a good result and to reduce the invasivity for our patient. And at the end, I'm glad to show my new textbooks just came out in the Italian version, but in the next month it will be available also in English version, edited with Dr. Aaron Garg, about the piezosurgery treatment of impacted teeth. New minimal invasive approach also in the extraction of impacted teeth using a new device, a new ultrasound vibration like piezosurgery device to reduce the ostectomy, to reduce the invasivity, to reduce the edema, the swelling during the extraction of the impacted teeth. And it will be available, I think, in next months, also in English version and also in US with the preface of the Dr. Aaron Garg. So thank you for your kind attention. I hope it was all clear, and if you have some question, I will answer you. Thank you very much.
Yes, Dr. Cardarelli. There is a question under the Q&A. If you can help answer that question. I can't hear you. Can you hear me?
Okay.
All right, doctor. So there is someone that asked under the question and answer. Can you answer the question? It says, what about daily hygiene and maintenance? When do you have to take off the prosthesis to clean underneath it?
Okay. Sorry, can you repeat it because the sound is lower?
Oh, sorry. Let me make sure it's good here. Okay, it says, what about daily hygiene? And maintenance. When do you have to take off the prosthesis to clean underneath?
Yeah, about the maintenance hygiene is in this type of the rehabilitation is it's easy if you use a particular device to obtain a good maintenance between the fake gingiva and the soft tissue. And every year, after 1 year, I unscrewed the provisional rehabilitation, I checked it, and I used the particular tips to clean around the multi-unit abutments every 1 year. Is very, very important. And for the maintenance, it's very important to use a particular device like the water pressure to obtain a good clean around the implants. It's very, very important. And X-ray check every year.
Good. Another question came in. What is the name of the device you use to verify muscle activity at the end of your lecture?
This is the Titan. Titan.
How do you spell it?
I can write the name. This is the electromyography device. The exact name is Titan.
Oh, there you go. Okay, perfect. Copy and paste. Perfect. Dr. David Ting says, it seems like the surface of the prosthesis are concave where the hybrid meets the gingiva soft tissue. Is that correct?
Is very important. Depends from the shape of the soft tissue and from the bone resorption. Because if I have an extreme atrophy, it's necessary to have a sufficient artificial gingiva. But the external shape of the fake gingiva should be convex to obtain a good clean during the procedure.
Got it.
And the base of the provisional rehabilitation should be flat. If possible, should be flat.
Okay, good. All right, everyone, a couple more minutes for some questions. Doctor, thank you so much for that. And so far, people are saying thank you for your, generosity and your time. Oh, another question just came up. How long do you keep the prosthesis out of OCC, out of occlusion?
How long, sorry?
How long do you keep the prosthesis out of occlusion?
In the provisional rehabilitation, the final?
Good question. I don't know. I don't know. Probably the provisional, I'm assuming. The final.
About the cantilever?
Yeah. The question is not very clear. Dr. Isdi, you can go ahead and ask in the chat room as well if you could. Then Dr. Cardarelli would try to answer as much question as possible. Let's see here, another question. Is there gonna be any re-runoff of the recording? Yes, we will. This is pre-recorded, so we will repost this for you guys, okay? Okay, let's see here. Another question came in. Oh, a lot of questions coming in. How do you fix fractures of the temporaries?
Yes, in case of the fracture is a problem during the medial loading. And if we have the fracture of the provisional rehabilitation, it's possible to have a not osteointegration of our implant. So it's very important to use a good material to avoid the fracture of the provisional rehabilitation. In this case, in case of the fracture of the provisional rehabilitation, it's necessary to unscrew it and to repair the provisional rehabilitation. And if I have the peri-implantees not osteointegration of our implant, is necessary to remove the implant, to place it at the same time new implants, and at the same time I do medial loading.
Okay, hopefully that answers your question, Dr. Said. Okay, another question is, can you, from Dr. Ting, can you also elaborate on marking of the outline of the anterior border of the sinus? Were you simply drawing or on where the sinus bulges out?
For the sinus, in my experience, I never used the surgical guide. It's possible to mark the shape of the sinus with the pencil, but depending from the knowledge, from the skills of the oral surgeon. In my approach, I use a good skeletization of the bone to obtain a good view of the sinus, and it's possible when it's possible to see the shape of the bone using the sinus, using the pencil to mark the anterior wall of the sinus.
Okay. All right, so that was Dr. Ting. Dr. El Said says, what is the critical time to touch the temp for adjustments?
It's possible to remove the provisional rehabilitation until 2 weeks after the surgery. After 2 weeks, it's not possible to remove the provisional rehabilitation for 3 months later in the mandible and 6 months later in the maxilla. So it's possible to remove in the first 2 weeks. To remove, for example, the suture, but I use always the resorbable suture. After 2 weeks, it's not possible to remove until before, after, it's possible to remove, after 4 months in the mandible, 6 months in the maxilla. Nice. Before, it's not possible, because this is critical time for the osteointegration.
Got it. Dr. Ting made a comment. He said, I was intrigued to see how you can place the tilted implant exactly along the anterior walls free-handed. So he's very impressed with that.
Depending from the knowledge, from the experience, but it's very important to have a good view of the orthopanoramics and the CBCT scan.
Perfect.
And to have a good sensibility in the hands. In my practice, I never used the surgical guide, but using a good bone skelettalization, it's possible to see the bone shape is our goal in this approach. And in the mandible, it's possible to have a good inclination of the tilted implant to check always the emergence of the mental nerve. It's very, very important to check always the emergence of the mental nerve.
Got it. One question from Dr. Haman. Can you show everyone the instrument of the intraoral tongue retraction? Can we see it?
For the retraction, and we have a different type of the retraction instruments, and I made a dedicated kit for this type of surgery. If you want, I can send you some information about that.
Perfect. Yeah, you can email that. That'd be great.
Yeah.
Another question is from Dr. Levencher. Do you use zygomatic implants if atrophy is generalized over the whole maxilla?
Zygoma implants?
Correct.
I never used zygoma implants in my experience. It's possible to use zygoma implant is another way to treat this extreme atrophy. But personally, I think is extreme rehabilitation. And actually, there aren't many studies about the long survivor about the zygoma implants. So it's extreme surgery, and it's possible to have some risks to treat with this approach. So actually, I think there aren't many studies about that.
Okay, great. Let me look at the questions. I think that ends all of our questions so far. None has came in. So Dr. Cardarelli, always a pleasure having you. Thank you so much for our attendees. I'll be snapshotting everyone that joined so that we can send out your CE credits. Dr. Cardarelli, once again, thank you so much. Be safe over there in Italy, and we'll try to do the same here.
Thank you very much for your kind attention, for great support, and I hope to meet you very soon in Los Angeles.
Likewise, we'll look forward to seeing you, Dr. Cardarelli. Goodbye. Thank you, everybody, and we'll be having a course tomorrow as well, a webinar with Dr. Suk Hong on using the ozone with COVID-19. So it's going to be a very, very interesting course, and I'm looking forward to that as well. But thank you so much, everybody. Stay safe. Have a good week, and same to you, Dr. Cardarelli. Goodbye.
Best greetings from Italy.
Okay.
Bye-bye.
Bye-bye.